This is the Equity Charter podcast, where we talk about why we care about equity in the digital health sector and why we think you should too. Welcome to this week's episode of the Equity Charter podcast. My name is Aisha Rahim and I'm a psychiatrist and Chief Clinical Information Officer working in the NHS. Along with my colleagues Hassan Chowdhury and Victoria Betton, we developed 10 principles for embedding equity within the digital health sector. This week we'll be looking at Principle 9, which is equity in the use of data and design of algorithms. So here to discuss the topic with us today, we have our two experts, Rony Arafin and Maxine Mackintosh. So Maxine and Rony, welcome to the show.
Thanks for having us. This is very exciting.
Thanks for having us.
Brilliant. So we're going to start with you, Maxine. Do you want to say a little bit about yourself and your current role?
Yeah, so I am very obsessed and have been for quite some time with this intersection of sort of data, AI, equity and ethics, and then health and genomics and life sciences. And I've always tried to do kind of mishmash of things at the intersection of those three elements. So I'm currently working at the WHO as a consultant in their health inequalities monitoring team. I've got a very part-time role at the University of Oxford looking at sort of AI, equity, ethics questions for health. And I bloody love a community. So that's probably the main thing that I will gas on about of this podcast. And there's two communities which I'm sort of deeply involved in. One is called One HealthTech and one is called Data Science for Health Equity. And both in different ways try and champion better use of technology and data to promote health equity.
That sounds absolutely fascinating, and we will definitely be coming back to some of that you've just mentioned. And if I now go over to yourself, Rony, tell us about you.
Thank you, Aisha. Delighted to be here. I'm Rony Arafin. So my day job currently, I'm doing the Director of Insights role at the British Heart Foundation. But my experience has been in the health industry for over 2 decades, working at various NHS organisations, acute trust level, ambulance trust level, community level, then the ICB level, and then I was head of analytics at NHS England just before joining British Heart Foundation. So yeah, I'm obviously working in data analytics quite a lot, and then I wear different hats. So I was the CEO for Association of Professional Healthcare Analysts for 4 years, AFA, and then currently I'm also the National Deputy Chair of the Chief Data Analytics Officers Network. So all of them connects health data, health and social care data, space in data and analytics. So hopefully I will be able to add my 2 pence worth in this discussion.
Well, fantastic. You're both obviously extremely experienced, and I'm hoping to learn loads from this conversation. So thank you for joining us today. So I'm going to kick us off with a starter question, really. Why is it important to proactively think about equity within the data world, would you say?
I'm happy to kick us off. Sort of stating the obvious, data is a digital representation of the world around us. And the world around us is horribly unfair and discriminatory and represents decades, centuries, millennia of power imbalances. And, as far as those things are codified and represented in the data sets that we have. So that sounds very sort of high level up here. But what that really means is that, the racism that we experience in the healthcare system, the misogyny that we experience in the healthcare system, the financial inequalities that people experience within the healthcare system obviously gets represented in the data sets that we have. And so what that means is that if we don't pay special attention to it, and then suddenly we start to build analytical models on top of these data, we're going to perpetuate these inequalities, and sometimes perpetuate them without being aware that they're even there, because data sets are kind of like numbers and columns and you can't really see the inequalities because it's just sort of mathsy stuff. And increasingly, as people are making decisions based on algorithms, based on AI, and not necessarily understanding where they're coming from, I think there's a real risk that we blindly continue these discriminations in our data and in our data-driven decision-making. So that's, for me, the top line of why we really need to be paying attention. And without that, I think we'll just sleepwalk into making sure these inequalities exist forever, really.
And similarly for me, Maxine, as you said, I think we have lots and lots of data in health. But actually, when we try to do a modeling or try to do any kind of insights analysis, we always have to be aware of how it's impacting people in different ways. So if we're really truly thinking about giving a personalized service, actually the equity inequalities, these are pillars of things that we really have to really think about as a core. So another thing for me, you might know this already. So recent Institute of Health Equity analysis shows that there are over 1.2 million people. Their lives were cut short between 2011 and 2020, and 90% of the areas in England as a result of avoidable socio-economic disparities. Actually, loads of factors we know that data is telling us, but actually then we fail to really take actions. So I think it's weaved into our analysis, weaved into our insights. We are exposed to lots of equity and inequality issues, but we're not seeing the actions that we really need to see. So actually, this discussion of this topic is very, very relevant. There's lots of fantastic works going on. I think we still need to do more. So I am looking forward to the rest of our discussion as we uncover more about this.
And that's a really important point, isn't it? It's all very well having the data, but unless we're doing anything with what the data is telling us, then we're only really doing half the job, aren't we? And so I wanted to think about, in a little bit more detail now, the entirety of the data lifecycle, because I'm guessing that there are many different stages at which inequity creeps in or exists. And I suppose there are lots of different ways, that means, of tackling this. And I just wonder if either of you had any insights into the different ways in which inequity plays out within that data pipeline.
Even the framing, Aisha, I think is really important to sort of hammer that point home, because I certainly feel that sometimes people say, "Oh, it's the AI models. They're the ones that those are the things discriminating." It sort of puts this responsibility on this sort of computer, and actually, there's a domino effect of so many points at which bias can enter into a data-driven pipeline. So even that framing, I think, is something to really sort of retain if you're listening. The way that I like to break down this at times quite overwhelmingly big, complicated technical spaces into all the different stages of the pipeline. So that the questions we ask, to what extent that informs the data we collect, to what extent that informs how we build models, to what extent that then influences how we then evaluate the models and then do the equivalent of sort of post-marketing surveillance, and then all the things that sit around it, so the makeup and diversity of, say, the workforce doing that modeling. So for me, those are the sort of stages at the very high level of what is made up of a sort of AI pipeline. So just taking a few sort of factoids from that. So if we look at, say, the sorts of questions that we ask, only 10% of global health funding is spent on where there's 90% of preventable deaths. So wow. We really do not concentrate global health funding where there is the biggest need. So even that, when we step back and we look at the world, we are just not funding where the need is. And obviously that then trickles down to the data sets that we created and the work we do on top of it. We all will have different, if we go next to the data sets question, we've all got different data sets that have different disparities and differences within them. There is no such thing as an unbiased data set, but what's important to understand is how biased and in what way. I used to work in genomics, and I find genomics one of the biggest data bias, most starkest data bias problems. So about 85% of our genomic data is made up of individuals of non-European ancestry. And so that really is Northern, Western Europeans. So that's basically US and UK and a bit of Scandis. And, the world is not 85% white European. And then when you look at the models that are built on that, things like polygenic scores, which is a type of risk score, they consistently perform better, unsurprisingly, in individuals of European genetic ancestry compared to other ancestries. And so you sort of rarefy these discrepancies. I won't go through each of the ones. Other facts are things like, 15% of the AI workforce are female. When I did a PhD in AI, there were about 50 people in my cohort, 2 women and 1 non-binary person. Now it's way, way better, but still the numbers are very stark. Not to say that being a woman makes you particularly good or bad or different. You just think about things sometimes in a different way. But there's so many different things you can do. And I think that if you are trying to debias any sort of AI, you have to break it down into these little segments and then work out what's the kind of small thing I can change at this step, and make sure you're doing something at every single step, because without that, then you might be sort of hitting your analytical pipeline at the wrong place.
Lots of things you said resonates with me. So I think, as you talked about the biased data set or unbiased data set, that kind of thing, but it's been going on for years and years. Over the decades of people are collecting data. So if the access and the treatment is unequal, whatever analysis and insights we're presenting, would it still be unequal? So we need to really think about, we're training a model, training a data set, but training with biases, unbiases, or whatever we think is within it already. So we have to think about utilizing all of the resources we have available in a different way to really surface what problem we're trying to solve. we know this already, like people, where you live, your ethnicity, all of that, some of the strongest factor that matters. So it's kind of multifactorial thing that influences your inequalities, creates equity, creates disparities. What's really interesting is also, though, this is not just limited to one condition. Like for me, I'm working in cardiovascular disease at the moment, so our focus is that. But everything we look at around inequalities of equity in cardiovascular care replicates throughout other areas. So anything you look at, prevention, diagnosis, treatment, and outcomes, that probably falls into the same pattern for all of the disease areas. So for cardiovascular care, we know that people in most deprived communities, they're twice as likely to die early. This isn't good enough, not anymore. We have lots of data. The world is moving to lots of advanced analytics and AI, but things are still happening. People often develop multiple long-term conditions 10 to 15 years earlier than it could have been prevented. And so I think lots of the signals that we get and the insights we have is visible, but things are still not changing. So there's obviously something missing. And particularly, I think when we talk about the whole thing around inequalities and equity, I think sometimes people do miss the personalized, the person in the center of all the data. So when you're looking at big data sets and making an aggregated decision, so for departments, for politicians, for national bodies, you're looking at a very aggregated big data sets. But underlying all of these things is actually people. They are giving us all of this information, and that's fragmented in multiple places. I think that some of the inequalities and equity discussion comes in because they're having to go to different health service providers and always replicate their records in different ways. And then when you bring this in an aggregated way, you're missing the person's personalized health. And I think so that's really important when we think about joining up and linking data set. We always have to remember that it is the people who are going through different areas of the same system.
Just to dovetail on that, I think, and maybe this addition is for the particularly more analytical people listening to this podcast, but time and time again, when you look at how some of these more AI-based models are performing, it might be like an AUC of 0.9, which is a very good performance. And we're like, great, that's a great analytical performance. And then you look at where the error is distributed, and you're like, oh, actually, the aggregate score is 0.9, but all of the error is distributed amongst Black people. And so it's like, as a data set, it's kind of, in the model, it performs quite well, but actually all of the mistakes are concentrated within a certain group of people. And then you think, gosh, if you were of a certain age, ethnicity, gender, socioeconomic class, and the model just didn't at all work for you, like that's such a horrible thing to know, even though the model and the data set overall works. And so I guess that just goes back to Rony's point that, when it comes to inequalities, you've got to be able to kind of oscillate between looking at the data, looking at the scale, looking at the size, and then thinking, but actually, if you were a person in this data set, what would be your experience of that model being applied to you and your use case?
That's such a fantastic segue into what else is in my mind at the moment, and thinking about the disaggregation of that data into constituent parts by cohort, by demographic. So I work on the front line as a clinician, and one of the things that keeps cropping up for us is how bad we are at recording protected characteristics and being in a position to even extract that data as to how it affects different groups, how it affects women, how it affects people with disabilities, etc. Is that something that you see replicated, that difficulty in even collecting the data in a meaningful way to make those judgments, being able to identify where those biases exist? Is that something that you've come across regularly?
I can give you an analytical answer. I'm sure, Maxine, you'll have your take on this. It is in the NHS and in the health records, this problem around, if I just look at a simple ethnicity level recording, 1 in 6 outpatient records, 1 in 8 inpatient records misses ethnicity data is not recorded. So when we're looking at it, and this is not just the England problem, we're also looking at data sets, and it's Scottish data sets, Northern Ireland and Wales, they all have some sort of recording issue. So you do need to be able to really reflect on how the care is delivered. You have to have some of the data that's recorded at least, so then you can make decisions around it, because if it's not recorded, then that creates a problem. But I think that goes into maybe an incomplete data. But Saying that, though, you're never going to have something that's 100% right, because that's like a perfect world. We're never going to get to a perfect world. So I think we have to bridge a gap between what's good enough and what's perfection, and then base that on our decision making. Because we want to live in a perfect world where we have 100% completed data. Maybe that's possible, maybe that's not achievable, but we do still have a lot of really rich data and varied data in the health service for us to be able to do a lot of work that we can do now. What I'm trying to really say is that actually, although there is incomplete data, a lot of people might use this as an excuse for not to action and make operational differences right now, and that this is what's needed.
So that's a really interesting take, actually. So maybe we are spending too much time fussing over that bit where we still haven't got quite the completeness that we want, and that paralyzes us into inaction, when actually maybe our efforts should be better placed into other ways of making impact and picking up those things. That, yeah, really interesting. We've talked a lot about some of the dangers and the risks, but also using tech for good, data for good, to actually reduce health inequalities is something that often gets overlooked in this conversation. So I wondered if both of you had views or examples of how we might think about where the positives lie of technology in this field.
Yeah, I mean, there are so many. I think it's definitely easy to sit and throw stones in the face of new technologies and innovations. I guess taking a kind of analytical lens to it, there are loads of computations, thought processes, decisions that lend themselves much better to, say, algorithms than humans. So anything that involves like really complicated, multifactorial, interdependent decisions, like primary care is such a great example. You know, my husband's a GP, and he comes back basically every day from clinic saying, you know, I've been humbled by how ChatGPT can pick up stuff that I just did not know. And I think that those incredibly complex interdependent decisions and understanding, that's a fantastic AI problem. Get AIs to look at that. I think that it's what we do with the time or the capacity that these models liberate for us, and whether we choose to use that time to influence the human connection that we have, say, with patients. I think that's where some of the AI can get sort of a bad rep for maybe ostensibly adding more load and not saving sort of capacity or interest. So the thing that I'm really interested in is I'm trying to do some work at the moment which basically sort of maps the areas where human decision is most inconsistent or most biased, and to then work out and then map where AIs are best at making those sorts of decisions, and sort of trying to sort of do a reverse mapping to be like, we know we suck at these decisions, get AI to do that, and then save our decision making for where AI plays the least. And at least that way we can start to be a bit more thoughtful about where AI and humans should play, rather than, I think sometimes we get a bit lost in this AI, doctor, patient, human machine. We don't quite know how these things interact. So I think that's certainly top of mind for me at the moment.
That's really fascinating, Maxine. So I think I absolutely agree with you. I think this is also a cultural shift. So I've been having some conversation with colleagues. If you can think about AI or any other technical tools as a support tool, really, to deliver our work as humans, this changes the perspective, right? A lot of people's mind, they think that actually AI will be, I'm going to go to a AI doctor, and that would be the AI, and it will give me everything. But actually, if the AI supports the doctor, and doctors then relating that message, reviewing that back to you, then that is different. A real example of that is people, ring helpline, NHS helpline or charity helplines, and sometimes they need dietitian advice, they need particular disease area advices. And then we have to relay that message back to people in a letter based on what they have heard. So now, depending on someone, we all have different way of responding to people, right? But if clinically, actually you want a consistent messaging that remains consistent. But so those kind of things, like you said, that letter generation, gathering the information from clinically and the sources that's already published, you can do that via AI. But the nurses or senior nurses who are actually receiving the call, they could just look at that letter and approve or disapprove. So it's freeing up their time. Actually, they can reinvest their time into doing more things that not only which is appropriate, but I actually think that they can enjoy more Who likes writing letters? Who writes writing? Lots of. I remember working in mental health services where clinicians used to see people for 20 minutes appointment, but it used to take 2.5 hours to write that in a system. I'm pretty certain that still exists in various parts of our health system.
I can attest to that. Definitely still exists in my clinical
we got to change that, right?
Rony's already heard me tell the story, but I find it one of the most proximal and heartwarming stories of the use of AI around inequalities. Not all my anecdotes are from my husband, but he does produce a lot of anecdotes for me. So he, very frustratingly, he bought the latest AirPod Pros, the ones that are very, very expensive, but the ones that do simultaneous translation. And a very, very elderly woman walked into his clinic with, I think, her daughter or son, and there was a kind of complicated translation, intermediary. It was one of those slightly complex GP consultations. And then he had the idea to give this elderly woman one of his AirPod Pros, and then ran the consultation with simultaneous translation. Anyway, she just beamed. It was apparently just a complete turnaround, and the tone in the whole consultation went very well. And then as she left, apparently she was screaming with joy down the corridor saying, "I cannot believe there's a white doctor in Headington who speaks Hindi." And she was just apparently absolutely dancing down the room, this kind of 90-year-old. So I think, again, that's a really good example of how we use technology, and particularly AI-based technologies, to make interactions more human. And that's, and that example obviously has a very strong inequalities angle as well. So more of those little sparkly, delightful stories.
Oh, I love it. It feels very Star Trek-y, doesn't it? It's amazing.
That's amazing, but that actually does reflect. We've done a lot of patient survey, actually. Last year, we reached out to over 2,000 patients to just think about cardiovascular care and how they feel. They all said the same thing, the inequalities angle. People want access to the information and access to the people who can speak their language. Sometimes because of the language barrier, people's perception is they've been treated differently, although actually the treatment is fine. It's just how they perceive, or they're switched off before even seeing a doctor or a consultant. So a massive difference, actually. This is a really good way of interacting with people. I might have to invest in some of those examples when I go into different countries.
It's too expensive. Don't do it.
Maxine, I'd love to come to you next, because you mentioned various communities that you have co-founded and that you've been involved with. And one of the ones that you mentioned was Data Science for Health Equity. And I'd love to hear more about that, if you could tell us a bit more.
Yeah, so I started a community called One HealthTech now 10 years ago, which blows my mind. And I guess through that, I saw the power of volunteer-led communities and how you can kind of amass this sharing and collaboration, enthusiasm and joy, and reducing the barrier to technical topics. Again, very similar kind of tone and style to Equity Charter. I think there's just so much value in these sorts of communities for making complex or knotty or technical topics, or even just topics that are just too at the frontier that institutions can't keep up with, and making those things feel accessible. So big lover of all communities. Anyway, so I've been doing One HealthTech for about 5 years, and then I was doing a postdoc at the time. It was quite like a technical postdoc, and so I was in a statistics lab. And I was just kind of talking with a friend, and he was saying, and we were writing a paper about the generalizability of polygenic scores. So the example I gave before, these risk scores that you apply in genomics and tend to perform less well for individuals of non-European ancestry. And we were just reflecting about the fact that in the statistics world, people just don't really understand how to consider questions of inequities, particularly in health. And people come at this from a kind of causality or generalizability or statistical stability angle, and they sort of don't really know what that means when it comes to the real world equity question. And so we, as a lover of all communities, I thought, I don't care what the question is, the answer is going to be community. So let's do a community. And effectively what we did is we got people together, but really targeted at people who have very technical backgrounds. So these are mathematicians, data scientists, people who got PhDs in statistical machine learning, to matchmake them with people who are experiencing sort of frontline, and I mean like frontline analytical problems, and also frontline sort of public health problems that have big equity issues where better and more robust use of data and data science is needed. And because there is so much misuse of data and data science and the methods around it, but therefore lots of value add, that if you were to use the right methods in the right way, what can you uncover, what can you show, what can you address? And so, fast forward a few years, we've got about 3,500 people in it. We've got a really big CI UK grant to look at that in the context of cancer and lots of other conditions. It's a very, very international community, and people cluster around, various different domains where, again, statistics and data is not used as well as it could do to advance health inequities. So if you're someone who is either very very technical, who wants to provide your skill sets to health equity, please join. And if you're someone who's really grappling with how do you make use of data in a sophisticated, nuanced and appropriate way, then there's a bank of very keen technical people looking to help you. So that's my little pitch for us.
Well, I'll definitely put a link in the show notes to your community so that if people are interested in joining and collaborating, then they can head your way. Fantastic. And Rony, so if I come to you now, so you, of course, are the former CEO of AFA, the Association of Professional Healthcare Analysts, and currently you're the Deputy Chair of the Chief Data and Analytical Officers Network. I'd really like to get your views on what the appetite for thinking about equity is within the data community. What have you heard? How much is this on people's radar, would you say?
Thanks, Aisha. It's a mouthful to talk about AFA and CDAON, but I think what we're doing, and Maxine, you talked about community, so really the intention was to bring the community together. And for the Chief Data Analytical Officers Network, the CDAON perspective, we want to bring together the leaders. So we've got 120 plus members across the health service, mainly in England, but also from other devolved nations, to really have that space to talk through how we can share our learning and do. And a lot of the discussion have been around how do we utilize the data that's available to really surface the equity, the inequalities, the imbalance of people, how they're receiving care, where we can really reinvest our energy into delivering better outcomes for people. Because I think predominantly you will know that health service always looks at, is our waiting times going to be improved in this percentage? Is our cancer rating, is people turned up? So very, very operational indicators. I think less about outcomes, actually. And even if people are individually, organizationally measuring outcomes, they're not really delivering it in the way that they would probably publish their indicator or key performance indicators, for example. So I think a lot of the inequalities discussion, equity discussion, deriving from the data, what it gives, ultimately improves the patient outcome, right? Patients' lives who's coming into, and that's our underlying purpose of working in the health service, to improve people's lives. So I think there's a major drive to do this and do it consistently. So I think more and more discussions are geared towards, rather than leaving inequalities and equity as a separate area to look at, weave that into every single analytical work that goes on, whether it's AI, machine learning, creating a model. And if any of the analytical experts listening to this, I would encourage you to really think about bringing the inequalities, equity as a core part of the decision making throughout the whole product that you're developing, whatever that is. So it needs to be a core part of everything. It's not a separate thing. So I think more and more is happening on this space, and people are thinking about it because actually it drastically improves people's experience and the outcomes of their lives.
Can I just add something onto that? I feel that there's always an extra thing one needs to add. There's always a new thing one needs training. One needs to consider equity now in the analytical pipeline. And I can just hear people's eyes rolling to be like, we've got so much on our plate. We've got to do another thing. And so one angle, I guess, that I've found to be quite useful recently is that equity is what every analyst or someone working in an analytical job should be considering, because we think about it anyway in the terms of accuracy or precision or effectiveness or efficacy or quality, depending on how analytical or implementation you are. These are all terms that if you are a sensible decision maker or a good analyst, you should be doing anyway as part of being a good professional. Equity is a slightly different angle on those things, and I think that seeing it as a new thing can sometimes detract from the fact we know that all of those elements around quality, efficacy, safety, we should be doing anyway, and this is just a different lens on good professional behavior within those areas.
Yeah, it's a really good point, isn't it? And we've certainly had conversations in many different arenas about whether we frame this as an equity issue or is it reducing health inequalities, which actually definitely should be everybody's business. I mean, arguably equity should be everybody's business as well. But I think that framing as health inequality reduction feels like it resonates, I think, with a larger cohort of people, even if the ultimate goal is effectively the same.
Interesting, yeah. And the framing does matter, and especially if we look at the global climate and the conversation, that sometimes you can't even have this conversation in some form.
Yeah, absolutely. And so we've talked about some of the risks. We've also talked about some of the ways in which data can help us to address the existing bias that already exists. And we've had a little bit of a chat about pockets of really great enthusiasm around this within the profession. But what about the need for a national data observatory to think about this in a more global, bigger setting, I suppose? I don't know if you had any thoughts about that.
So I can come in, and Maxine, please do join in. So from the Chief Data Analytical Officers Network perspective, we often thought about there's lots of variety of data available, but there isn't a national expert advisory group of people who are already doing this work. So this was one of the needs that we identified to put together the Chief Data Analytical Officers Network. And from that, we are now finding more and more needs that there is not one, as you say, like a national data observatory exists in the UK. In various forms, they exist in different places. So we're trying to develop, and we just soft launched the data observatory. It's a CIC, it's a community interest company, supported by AFA and CDAON. But what we're really trying to do is bring together the health and care data into a more of a think tank perspective. So we want to tell people about what this data is leveraging, what is surfacing. But also, sometimes, you can read a lot of articles on HSJ, others, FT, this and that, but it doesn't sometimes offer you a solution. So we're really keen, actually, the national observatory or national expert, whatever it is, we need to offer solutions, how things can change. So you can surface your opinion, but you need to surface the solution. So I think this will be a new development. Watch this space. It will be supported by various different experts who are living and breathing the data and analytics space and in health. So I think we could do more. But there is an opportunity. I think what's missing is actually learn from other countries globally. So I'm also, for my British Heart Foundation, we are working on a cardiovascular observatory. So this will be just really looking at how people receive their care in cardiovascular world. And what we are finding, actually, there's various different data is available, but there's no kind of global comparison. So I think there's also a global need for us not only to have a UK-based observatory, compare our findings with what's going on globally around us, because the underlying problem might be similar.
Just a fantastic point, Rony. Just to add to that, I'm currently working in the Health Inequalities Monitoring team at the WHO, and they've got this thing called the HEAT and the HEAT Plus tool, and it allows you to do cross-country analysis on health inequalities. But obviously, the moment you look at stuff at that sort of supranational level, you kind of lose the granularity. So there's a really tough balance between country comparison or region comparison and then the level of detail that means that locally it allows you to do what you need to do. The only thing I was going to just, a podcast where we went to disagree a little bit with each other. I guess I'm always hesitant about institutionalizing very, very advanced domains, because the moment you create institutions around it, by definition, it becomes a bit slower and a bit more bureaucratic and will never keep up with the bleeding edges. But you also do need institutions to come together to standardize and be a lighthouse and a beacon for professions and work and partnerships as well. So I guess it's just to say that I think an observatory is and would be useful, but they has to be complemented by the equity charters, the AFAs, the One HealthTech, the Data Science for Health Equity, because data innovation happens in WhatsApp groups, on kitchen tables, in these chance encounters, and that's where everyone's learning these skills and tinkering and playing. It's not happening in formal professional bodies and in universities really anymore. And so you need these two, and that's just the fact that data and data-based work moves so quickly that institutions, by definition, basically can't keep up with what's happening at the bleeding edge.
So maybe that kind of pluralistic model of lots of different pockets of innovation supporting that agenda feels like a helpful way forward.
I think that's a great point, actually, because the partnering and connecting needs to be there. One of the issues currently we have is that, like you said, there's lots of great innovation in parts of the health system here and there, where it's not consistent. So really connecting that and somehow facilitating it to spread across the system would be a really good way. So rather than really siloing as an organization, we are here and we just do this. It's just connecting nature and building communities. And I think this is why when I talked about the Data Observatory, we deliberately wanted to set this up as a community interest company because we want to move these things back into social good, actually, and also help people who are interested in this world, because not a lot of people go to schools and then they decide, oh, I want to be a health analyst, I want to be a health AI expert. So we want to encourage people to do that more, because this is quite an exciting area to work.
Fabulous. So if you do have more information, we will certainly put that in the show notes as well so people can find out more, Rony. Thank you for that. So we are coming to the end of our session today with both of you. So as a final question to both of you, I think that this field is often rife with misunderstanding and myths that abound. So if there is any myth busting that you want to do, this is the opportunity. So if I come to you, Maxine, are there any myths that you would like to bust?
There are, oh my gosh, there are so many. So I'll choose one. Otherwise, you're going to kind of look at your watch to say that this podcast is meant to be shorter than it actually is. So I'll go for one that's a bit more analytical. So a huge source of problems when it comes to bias with AI and data-driven models is the poor use of proxies and proxy data and surrogate data, and sort of munging together categories of data and thinking that we're doing an okay job. And honestly, so many sources of biased algorithms comes from the misuse of categorization. And so the one example I wanted to zoom in on is we sort of have this obsession that disaggregating by socially constructed demographics like gender and ethnicity is the best thing to do. We've become slightly obsessed with it. And very, very often, when you disaggregate by a socially constructed category, you actually make your model more, say, racist or misogynistic than actually if you hadn't, because you create these arbitrary differences between socially designed categories of people. When actually often what's happening is those categories are proxies for other things like culture or multi-generational households or religion or language. But we kind of hone in on the things that we know we can measure, like ethnicity. And so I guess my kind of plea is, if you're trying to capture and understand someone's experience of, say, racism within clinical care, then absolutely disaggregate by ethnicity. If that's not your question, then you create artificial and arbitrary differences in ethnic groups if you start to do that within your models. So just be really, really thoughtful about how you disaggregate and whether that's actually the question you're trying to ask, or whether you've just said to yourself, my boss needs me to disaggregate by some stuff. That feels sensible. So be thoughtful about disaggregating is probably the thing I would want to leave people with.
That's really interesting, that nuance. Thank you very much for sharing that, Maxine. Rony, over to you.
So kind of similar. So I need to put this into a data perspective too. So my thing would be that myth busting, you said, Aisha, sorry, I'm trying to remember the myth busting, what I was going to talk about. So better data alone will solve health inequalities. A lot of people think that, oh, if we have really, really great data, it will solve health inequalities. So better data will help it, but it won't solve health inequalities, because data can help you highlight inequalities. Data can really help us navigate. But what will solve the thing is that people will, and I think we must remember that people will need to do service redesign. They need to build trust with communities. They need to build trust with people. They need to, of course, use data to really guide what decisions we're making. But data can't fix the inequalities on its own. It's the people, it's we together. We need to fix it. And it's actually when we're guided by that data. But when we come together and really put ourselves in each other's shoes and feel that how the other person is feeling, I think this is the only how we will solve the problem. And Maxine, you talked about before, when we talked about global comparison and local needs for really look at granular level data, I think things will be different. People's care and their needs of how they want to receive their healthcare will be different at an individual level, at a group level, at neighborhood level. And now we are thinking about doing all of these different things around reshaping our health. I think this is a great time to really think about how we can be signposted by data, but really as people really bring our human self to it and make something happen.
Well, what a fantastic point to end on, because I feel like we've come completely full circle from where we started about turning those insights into actionable insights. So all that remains for me to do is to thank you both very much for your time. Thank you, Rony and Maxine. Thank you for tuning in to this week's episode of the Equity Charter podcast. Don't forget to rate, review and subscribe to the series. And if you'd like to know more, go to our website at www.equitycharter.digital. You can follow our page on LinkedIn, join our community of practice, and you can also contact us at hello@equitycharter.digital.